Tantor Audio, a division of Recorded Books, presents Leading Through a Pandemic, the inside story of humanity, innovation, and lessons learned during the COVID-19 crisis, by Michael J. Dowling and Charles Kenney. Narrated by Campbell. Forward. Report from the front. Emily Fawcett, RN. I took care of a veteran on the palliative care unit of a COVID floor at Lenox Hill Hospital in Manhattan. He was in his 70s, dying from COVID. His children wanted to come in and say goodbye to their dad. Since the pandemic, we've been very strict on visitors, but if somebody is actively dying, we try to accommodate the family, so we arranged for them to come in and say goodbye. Our nurse manager, Renee Sanchez, whose dad is also a vet, said we had to do something for this family. The children came in and we all geared up in our personal protective equipment, PPE, and went into the room too. They were extremely proud of their father and his service to our country. The son and daughter both spoke about their dad. A vet who works in our hospital, Frank Cashel, said a few words of appreciation. Deirdre O'Flaherty, our director of nursing, found the U.S. Navy band's version of the Star-Spangled Banner, and she played it on her iPhone. Deirdre's husband is also a vet. The children were emotional, but they had this beautiful moment, which so many people didn't have during COVID. A lot of people have died alone. I think this family at least had their peace. They got to say goodbye, and we cried with them. Around that same time, I was taking care of a lady in her 70s whose husband was very sick. I really got to know her. I had met her in the emergency room the week before because her husband had come in very, very sick from COVID and had to be put on a ventilator in the ICU. I'm a float nurse, so I work everywhere in the hospital, which gave me a very good perspective during this whole thing because I saw it from the lens of the emergency room. I saw it from the lens of being on the actively dying COVID floor. I saw it from the lens of being in the critical care step-down unit trying to save people. I kind of got a full spectrum of treating COVID patients. A few days after her husband was admitted, this lady became sick also. She was very vibrant, very young for her age. She was on oxygen and definitely sick, but not as sick as her husband. I was taking care of her on a unit that was the next hallway over from the ICU where her husband was, but she couldn't see him. Couldn't be there with him. She couldn't hold his hand or touch his face. All she could do to feel connected to him was to pray for him. At night I would be with her and we would pray. She was lovely. She was extremely sick herself, and yet she was so nice to me. We cried together. We held hands together. I was pretty tough on her. I made her get out of the bed and sit in the chair, and she was huffing and puffing. She wasn't eating, so I made her eat. Every day when I walked in, she was like, "Emily." Her husband was on a ventilator for multiple weeks. I thought he had no chance of living. He was extremely, extremely sick to the point where his wife and I had a conversation about who would make final medical decisions. They had no children, so we had to call one of their relatives to make him the health care proxy in the event that, God forbid, if anything happened to both of them, there would be a proxy to make their medical decisions. That was really hard. I felt really close to her. I actually thought her husband would not make it, but then he got the breathing tube out and came off the ventilator. This was when a majority of patients on ventilators did not make it, but he started to recover. I showed up for a shift after a few days off, and there they were together, she and her husband recovering in the same room. Before I even walked in the room, she heard my voice and she said to her husband, "Oh, my God, it's my nurse, Emily. This is the one who took care of me." And I loved meeting him and telling him how I had been taking care of his wife and how we had prayed for him. I will never forget that couple. They ended up going home together. At the beginning, there was so much anxiety. Would we run out of ventilators? Would we have to choose who got a ventilator? What was that going to look like? And then when we were at the top of the curve, I was just working, too busy to think about anything. Coming off the curve was very weird. You'd just gone through this crazy thing. I had no time to process it. I was running on adrenaline, running on anxiety. I've been a nurse for almost 10 years. I have never in my 10 years done an overtime shift. I always thought I was a better nurse when I had some time off and would come in refreshed. So the nursing office said, "Emily, are you okay? Why are you working so much?" I just felt this great need to be on the front line for my city. I wanted to be in the thick of things. I felt better being at work than being home in my apartment alone. I wasn't sleeping. I wasn't eating. I lost a lot of weight. I wanted to be there for New Yorkers. I wanted to fight COVID for New York. I wanted to defend my city against this weird virus that we knew nothing about. So I felt this calling. I've done a lot of mission work, a lot of mission trips internationally, Kenya, Venezuela, and for the hurricane in Puerto Rico. I'd worked aboard the USNS Comfort. I felt like I was on a mission for New York City. I lived at the hospital for that month and a half, and it was just where I needed to be. Introduction. Humbling Lessons. At Northwell Health, we started preparing for the coronavirus pandemic 22 years before it arrived in New York. In 1998, FBI Special Agent John O'Neill, head of the Joint Terrorism Task Force, told one of our senior executives, Northwell's Executive Vice President Kathleen Gallo, that he expected an attack on the city. In that conversation, Special Agent O'Neill expressed frustration. He said he had talked with people from various hospital systems, but that no one seemed to take him seriously. He told Gallo that he did not know when, where, or how exactly, but that he was convinced some kind of attack was coming. State-sponsored terrorism was happening more frequently, and non-state actors were growing in numbers and sophistication. Gallo was struck by the depth of the agent's knowledge and the intensity of his conviction. Their meeting led to decisions at Northwell that would forever change our system's culture and capabilities. Energized by what O'Neill told us, we hosted a conference on weapons of mass destruction to which we invited major health systems in New York. Most weren't interested. O'Neill was scheduled to speak, but was called to Yemen to investigate a terrorist attack on a Navy ship. He sent a colleague to fill in for him at our conference, and remarkably enough, O'Neill's colleague displayed a large photograph of a man no one in the room had ever heard of, Osama bin Laden. The agent said that this man could potentially attack New York. Tragically, after O'Neill retired from the FBI, he took a position as head of security for the World Trade Center in New York and was killed in the 9/11 attack. And here we are in 2020, with the coronavirus as the newest weapon of mass destruction. As we discussed the inevitability of terrorism and the need to prepare 2 decades ago, it was clear that many other types of emergencies could be headed our way as well. We made a decision to build a robust emergency preparedness infrastructure within our health system based on a simple assumption: bad things will happen. We have to be ready. But what bad things? Terrorist attacks, as the agent suggested. Also major weather events, utility outages, cyber threats, and the potential for infectious disease outbreaks, which have always been near the top of our threat list. We had to be ready for anything and everything. We set about making emergency preparedness a major capability within our growing health system, and toward that end we established a network incident command structure of a kind widely relied upon by military and law enforcement organizations. It is known as an all-hazards approach, on the theory that it prepares the organization for any type of disaster and involves the creation of an emergency leadership unit able to deploy personnel and resources from every part of the organization to wherever they are needed. We hired and promoted experienced emergency management experts, invested millions of dollars in equipment, and trained thousands of staff members. Creating this type of capability was unusual for a healthcare system, in part because it required a major financial investment with zero anticipated return on investment, ROI. A significant disaster response capability was considered the job of governments, federal, state, county, or municipal, and rarely the role of private health systems. But we believed that our emergency capability would one day save lives, and that is what it did during the coronavirus pandemic. At Northwell, we took care of more COVID-19 patients than any other health system in the United States. We nearly doubled our capacity of 3,000 beds in a matter of weeks, and that was barely enough. Our frontline workers saw illness and death on a scale none had ever witnessed before. The pandemic stands, without doubt, as the most frightening, overwhelming experience any of us have ever been through, and the most humbling. We were stunned by the power of the virus and the disease it caused. As we reflected upon the experience, we sought to identify lessons learned to help us, as well as others in healthcare and government, prepare for next time. Some of what we believed before the crisis was confirmed. Bad things will happen. Of this there is no doubt. And in order to care for patients, our absolute number one priority must be protecting the physical and emotional health of our staff, as well as ensuring their safety. We also reaffirmed our belief that an emergency management capability should be a core competence of every health system. Preparation rests upon creating a culture where emergency teams are valued and respected throughout the organization, and where emergency management departments are as essential to the organization as departments of cardiology or oncology. This is far from the reality at most health systems in the United States today, and one of the more dangerous holes in the country's overall medical capability. We learned that an emergency preparedness culture gives leaders the confidence to change and improve in the midst of chaos. Crisis situations are illuminating, and quite often, good ideas and improved processes emerge. Our long-held belief in the efficacy of an incident command structure similar to what is used in the military and by first responders was confirmed. This simplified chain of command enabled us to make crucial decisions faster than ever. We learned that the importance of relationships with vendors is magnified in a crisis, and that vendor relationships nurtured over time prove far more durable than purely transactional relationships. We learned how to expand our inpatient capacity far beyond what we had ever believed possible. We learned the remarkable morale-boosting power of leaders going to the front lines to be present with the troops, to support them, and to try in some way to help calm their fears. We learned that low-income and minority neighborhoods were particularly vulnerable to the virus, further highlighting persistent inequities in access to care and health outcomes. We learned the power of an integrated health system. In the pandemic crisis, the scale, adaptability, and integrated nature of our organization saved lives. Large integrated medical systems have been much maligned in recent years, but after this experience, that attitude may soften. We learned that by integrating research into the emergency response, we could perform clinical trials even during a crisis, producing data to benefit the entire world. We learned that acceptance of telehealth by patients and providers is growing because of its convenience and effectiveness. We learned, or rather, our belief was reaffirmed, that the major insurance companies are more interested in profits than people's health. We learned that stripped-down regulations gave us invaluable flexibility to perform quickly and effectively, that we can handle a major crisis and not buckle under its assault, and that we can collaborate well with competing health systems. We learned what real leadership looked like, Governor Andrew Cuomo's calm, fact-based approach. Our belief that politics has no place in the world of science was reaffirmed. We learned what it was like to be in the epicenter of a global pandemic, learned firsthand how to care for 16,655 COVID inpatients while we treated and released 10,465 patients in our emergency departments, cared for 20,506 in our ambulatory centers, and 2,231 in our post-acute locations, a grand total of 49,857 COVID-19 positive patients. Tragically, we lost 20 of our beloved fellow Northwell employees to the virus, numbers as of July 1st, 2020. And when there was a resurgence of the virus in parts of the country during the early summer, we were reminded of the harsh reality that the coronavirus will be with us for at least the foreseeable future. At Northwell, we had advantages going into the crisis. One was our size. 23 hospitals in the greater New York area, 800 ambulatory sites, post-acute services, medical and nursing schools, a major institute for medical research, a core testing laboratory, nursing homes and home care, as well as a centrally organized transport system with a fleet of ambulances that allows us to move patients quickly and safely. As valuable as our size proved to be, our emergency preparedness culture, developed in the years since Agent O'Neill issued his warning to us, proved even more important to our ability to deal with the crisis. Any hospital or health system, no matter its size, can also aspire to a culture of preparedness, and we should all be working together on developing this culture within all systems. In the time ahead, working with Governor Cuomo and leaders of other health systems, we will no doubt identify important steps that need to be taken in this process. But before we do anything collaboratively, there are two changes that are foundational. First, every hospital and health system, large and small, must develop a core capability in emergency management. This requires having the equipment and personnel necessary to manage any and all emergencies, from hurricanes to pandemics. Government financial support will be required for many organizations to accomplish this. Second, every hospital and health system, large and small, must do the hard work of creating a culture in which an emergency capability is valued and respected throughout the organization. Few organizations in the United States have achieved this level of practical and cultural readiness. We learned that in training to prepare for a disaster, you know you are ready when your organization is, in the words of one of our emergency management leaders, comfortable being uncomfortable in a crisis. It would be a mistake to believe that only large systems can be prepared. Healthcare entities of various sizes can certainly achieve an increased level of practical and cultural readiness. And given all that can go wrong in the 21st century, in the New York area in particular, with hurricanes, blackouts, terrorism, pandemics, etc., there is a responsibility to do so. We believe that practical and cultural readiness are prerequisites to the ability of healthcare professionals throughout the United States to coordinate efforts with other entities, with state and local governments, with first responders, so that no one is overwhelmed and all patients are properly cared for. The biggest story of the pandemic is the speed and lethality of the contagion. The next biggest story is the courage and professionalism of those who fought it on the front lines. Consider this scene that staff members faced each day, described by Dr. Lawrence Smith, Northwell physician-in-chief and dean of the Donald and Barbara Zucker School of Medicine. In the hospital, it is a very sad, stressful environment, almost surreal. I've been practicing medicine for a long time, and I have never been in a hospital where so many patients are on ventilators, completely sedated, completely paralyzed, not moving a muscle. Not a visitor in the entire hospital. Bodies lying bed to bed to bed, and the only noise in the room is the hum of the ventilators. And these patients never speak, never move, and yet they are all potential killers of the staff, because they're all shedding virus. I've been in ICUs and hospital wards for 40 years now. I've never seen what the inside of Long Island Jewish Hospital looks like right now, with just endless rows of bodies that are alive, but they don't move, and there's nobody there to tell you about them. The staff has never heard these people even speak in most cases, because the speaking ended when they arrived in the emergency room. It's surreal. It's frightening. In normal times, when doctors and nurses report for work, they have little fear of being harmed. But in this crisis, they lived with fear, especially early on. Not only doctors and nurses, but physician assistants, nurse practitioners, respiratory therapists, including pregnant mothers and many people caring for children or sick parents at home, still answered the call. They lived with the fear that they could get sick or even die, that they might infect a loved one. Some people simply couldn't handle it or felt that working would be too great a risk for vulnerable family members, so they went on leave from work. But the overwhelming majority of our people managed the fear. Many got sick, but most recovered and returned to work. In the modern age, the term hero has been much overused. True heroism is a rare and beautiful thing. Merriam-Webster's dictionary defines a hero as a mythological or legendary figure, often of divine descent, endowed with great strength or ability, an illustrious warrior, a person admired for achievements and noble qualities, one who shows great courage. This describes healthcare workers in 2020. The physical challenge of caring for gravely ill patients is one thing. The psychological burden is quite another. All frontline workers sacrificed their safety, and some gave their lives. These men and women, clad in scrubs, gowns, masks, and shields, made Hippocrates proud. They showed up, shift after shift, the pressure of fear in their chests, and cared for the gravely ill. They conveyed the final moments of loved ones' lives to family members via Zoom and FaceTime. They saw colleagues fall. They contracted the disease and died. As leaders, those of us in healthcare and government owe it to our frontline teams to do nothing less than scour this experience for lessons that will improve our future readiness. As Peggy Noonan put it in the Wall Street Journal, the hidden gift of this pandemic is that this isn't the most terrible one. The next one, or some other one down the road, is. This is the one where we learn how to handle that coming pandemic. Character reveals itself in crisis, and that was surely the case in the midst of the pandemic. Some hospitals and healthcare workers prepared well and weathered the storm. Others, lacking preparation, were overwhelmed. In too much of America, a lack of preparedness was on stark display. Doctors and nurses begging for masks, infected by those they treated. Thousands of patients died alone. Medical tents were set up in Central Park. A president claiming the situation was totally under control before more than 100,000 died. In May 2020, after the virus had passed the peak in New York, Governor Cuomo announced the Reimagining New York venture to plan for the new reality in the post-COVID world. He enlisted one of us, Michael Dowling, CEO of Northwell, to lead the healthcare part of that initiative. We hope the experiences and lessons we share in this book will help advance that initiative, and that, in turn, others across our nation will learn from what we have been through. In this book, we will identify lessons that apply not only to our health system, but to all hospitals, whether individual standalone entities or larger systems. The lessons we've written about apply to both private, not-for-profit hospital systems like our own and to public hospitals. The lessons, individually and collectively, will make clear the need for significant change throughout the healthcare delivery system if we are to be prepared for the next crisis, whatever it happens to be. Each chapter of this book summarizes essential lessons learned, and then tells the story or stories that reveal those lessons. Most importantly, we have synthesized the stories and lessons within the book and proposed a series of specific steps that healthcare systems need to take in order to be ready for the next pandemic. This 13-point prescription is presented in the final chapter, with the hope that medical and public health professionals, as well as government officials and the public, will recognize that failing to take the prescribed steps will leave our nation vulnerable to a far more severe attack from the next virus. Chapter 1. Epicenter, the peak of the crisis. Lessons. Staff demonstrates extraordinary courage, compassion, creativity, and resilience during crisis. They possess a natural desire to come together and succeed for the common good. Being part of a large integrated system has enormous advantages. Load balancing, the ability to transport patients from overwhelmed facilities to other hospitals, saves lives. This requires a central transfer system. Don't prepare for the worst case. Instead, expect and prepare for a reality even worse than that. Assess the long-term impact on staff dealing with anxiety, fear, and death. If you were searching for the epicenter of the COVID-19 virus in the United States, you would have to make your way to the borough of Queens in New York City, more specifically to 10201 66th Road in the Forest Hills neighborhood. There you would find Long Island Jewish Forest Hills Hospital, part of the Northwell Health System, where the virus unleashed its fury. Queens County, with a population of 2.3 million people, is the most diverse in the United States. A total of 164 languages and dialects are spoken there. Our hospital, where the #1 language is Spanish, followed quickly by Russian, is in the center of this diversity. Our immediate neighbors are largely Bukharan Jews who fled from Uzbekistan when the Soviet Union dissolved in the 1990s. Nearby neighborhoods such as Corona and Jackson Heights are predominantly Hispanic, while Jamaica and Richmond Hill are mostly African American, Caribbean, and Indian. In Flushing, there is a large Asian population, which is also growing in the area surrounding the hospital. The demography of this neighborhood made for a perfect storm. Tight living quarters, many multi-generational households with not a lot of ability for people to self-isolate, pockets of low-income residents, and high reliance on public transportation. At a hospital a 10-minute drive from Forest Hills Hospital, there was a dire warning of what was headed our way. A headline in the New York Times read, 13 deaths in a day, an apocalyptic coronavirus surge at an NYC hospital. The story focused on our Queens neighbor Elmhurst Hospital, which is not part of our Northwell system, but rather of the New York City public hospital system. In a harrowing Times story, a doctor at Elmhurst was quoted as saying, "I don't have the support that I need, and even just the materials that I need physically to take care of my patients. The anxiety of this situation is really overwhelming. We don't have the protective equipment that we should have. I want people to know that this is bad. People are dying. We don't have the tools that we need in the emergency department and in the hospital to take care of them." The Times reported that some patients at Elmhurst died in the emergency department awaiting treatment. Who would ever have believed that you would hear the words apocalyptic and besieged to describe the scene inside a hospital in a major American city? During a leadership team meeting at our Forest Hills Hospital in March, with the virus approaching, you could sense growing anxiety. The news from China and Italy was alarming. Team members engaged in emotionally charged arguments about what we should do. At this point, Susan Browning, executive director of the hospital, interjected forcefully. "Guys, stop. We have a surge plan. We developed the surge plan when times were calm. We are going to take that surge plan out right now, and we're going to talk from the surge plan. We are not going to make things up on the fly." Forest Hills is one of Northwell's smaller hospitals, with an average daily census of about 150 medical patients, typically a bit higher in winter and lower in summer. With the expected influx of COVID-19 patients, the surge plan called for us to open up areas that normally would not be used for patient care. We refitted the endoscopy suite to accommodate 15 new beds and emptied out a conference room and added 10 beds. We moved half of our maternity patients from a new state-of-the-art unit into triple-bedded rooms in an older part of our facility, and added 20 additional medical beds to the vacated maternity unit. We converted our 14-bay preoperative ambulatory surgery area to 14 inpatient beds. Our 8-bay post-anesthesia care unit accommodated 8 more inpatient beds, while at the same time we turned some medical floor beds into intensive care units. By the time the surge plan was executed,
Sample complete. Ready to continue?